Well, good morning, all of you. And I'm just going to wait for the few people to come in. This takes a couple of minutes as people arrive out of our waiting room and join us. For those people that are joining us today from across Europe, good morning. For those people who are joining us across from the rest of the globe, maybe good afternoon and good evening as well. Welcome to the first in our health data thematic innovation ecosystems. We're doing this in partnership with colleagues from Hitachi, who will be presenting later today, as well as in partnership with the Digital Health Society, our data arm of the ecch Alliance. Got a packed program today with some excellent speakers on the subject of synthetic data and the use of health synthetic data in particular. We've got excellent speakers from Finland, across Finland, Greece, and Portugal. Before we go into that, I want to just share a couple of, for those people who don't know who we are, the ecch Alliance, just a couple of slides on who we are and what we do, moments, and then hopefully we can then press on with the presentation. So hopefully you can see my slides. The ecch Alliance group, as some of you who don't know, we're a member organization, and we'll put in details in the chat function below. A little bit of information about us and a flyer, but in essence, as a member organization, we do one of four things. We either connect our members together, we convene them together in ecosystems just like this one, bringing people together that usually wouldn't necessarily work together in ecosystems. We see ecosystems as a very basic model of matching need and solution in health, and been doing so over the last 12 years. We've built a network of those over the last 12 years, as I said, of over 70 different ecosystems, as well as 12 thematic ecosystems, of which this is the first one we're launching, targeting the area of health data. We'll be continuing on these with further ecosystems, which will be looking at the European digital innovation hubs, as well as other areas around health data in the future. We also amplify what our members do and accelerate innovation from one part of country to another, from one country to another, and even one continent to another. We'll put details on how to join us in the chat function, but for those people who don't know where we are, you can see here a map of some of our ecosystems that are spread all over the globe. This is growing and is already out of date, as we're welcoming our new ecosystems from Austria, Luxembourg, and soon from Turkey as well. You can see here also the areas we've targeted for our thematic ecosystems. But that's the subject for today. So a thematic innovation ecosystem is bringing in cross-border best practice and identifying areas where we can collaborate, matching need and solution. So today, what we're able to do is bring in best practice from Finland, always held up as exemplars in this field, as well as Portugal, which we've been finding have been shining stars recently in this. And I'm really pleased also to welcome in our Hellenic colleagues from Greece, who've got some, I think, some really great practice to share. So good news is I'm going to stop talking now and hand over, and we're going to kick off with our first presentation. Okay. So who we got first? Yeah.
Yeah, I think it's my 4 slides on Hitachi network. So hello everybody, my name is Janne Lahtiranta and I'm presenting here today the national healthcare data and well-being data ecosystem Hitachi. Our network covers geographically most of the Finland, from Oulu all the way to the southern parts of Turku. And we have been working with the healthcare and well-being data for a couple of years now under a specific project that has been funded by the Council of Oulu region. And as you know, Finland is a small country, and in our network, we believe that together we are stronger than alone. And in our operation, we focus on capacity building, sharing our best practices in much of the same fashion as Andy just said. And we create services that play well with other regions, complementing their services with those of other regions. And in the core of our network are regional capabilities. And here I have listed what kind of capabilities we are having in different regions that belong to the network. And I have highlighted the Turku on the upper left-hand side, because we are going to investigate one of our region's specific focus areas, that is synthetic healthcare data. Over the last years, we have invested heavily in this area. And right now we are actually building a test bed that would offer synthetic healthcare data services to SMEs and research organizations as part of our European Digital Innovation Hub called Health Hub Finland, which is one of the ecchs that focus on healthcare data. Our other specialty area is the imaging data, and in that area we are hosting actually the HQ of the Euro Bioimaging Network. So those two areas are in the core of Turku region specialties. So next, we are going to hear more about synthetic healthcare data. And if you'd like to know more about our ecch network, please visit our webpage, or you can be directly in contact with me. So thank you.
Excellent. Thank you for that, Janne. Okay. So next.
I think we are maybe next.
Yeah. You and Lissy.
Yeah.
So thank you for the opportunity for us from BCB Medical to talk today. The reason why we most probably are here is because we are a small company from Turku. So basically we have 120 disease-specific registries. So we're the IT provider in Finland for these different data sources. And so if we look at this picture, I think it's really important to think about synthetic data. I'm now really talking about our experience from the 2 years we've been working on this. Finland received a very nice new Secondary Use of Health and Social Data Act, which means that if you look at the left-hand side, a customer can be any small, medium-sized company, it can be academia, it can be anything that where you want your data for research. So basically what we've also done is we have a pile of applications to be able to access this data for synthetic data uses. This system is really democratic, unfortunately, because it means that if you have a very complex application, which is quite useful, because the idea is that if you go through PIN data, you can combine a lot of the data sources. If you don't need to combine data sources, then you would do what we've done, which is much, much quicker. It would be just to go directly to a hospital and use that source. But you don't get this lovely complexity, what's possible in Finland with all the personalized identifications that can combine all the data from other sources. So basically, you don't have synthetic data if you don't have data. And this is just to show the background to what is the Finnish data landscape like. A lot of opportunities, but a lot of learning processes also. So the next slide, you see, just what do you do when you become a bit frustrated? Then you decide to write something more about the process. So anybody who's interested to read about Jussi and my experience on comparing the federated data sharing to the Fin data system, especially in the synthetic data context, because it's something that's new and not used so much. So we have a bit of legislative challenges that I understand are looked at right now and most probably are going to be fantastic in the future. We need to be positive and optimistic. So the next slide. And this would be my last slide, and I'll then give it to Jussi, because what I think right now from our experience is that there's a lot of data, but the validating the data, that's 80% of the time. We need to clean it and make sure that it's good enough. We also need to make sure that the data collection is made much more effective. We don't want to have healthcare professionals using time. So having the possibility to integrate data from different sources and processing it in an effective way, and especially in a safe environment. So the most important carry home, I would say, is what we have as a synthetic data challenge is definitely how the data is used. We need to have all our stakeholders on board. We need to have firm understanding. How can it be used more for research? We have smaller groups in the oncology field that there's no possibility we can do randomized clinical trials. We need to have these synthetic data arms available. And with these words, I will give it to my dear colleague, Jussi.
Thank you. Yes, I am Jussi Salmi. I have a PhD in computer science and I am a data scientist at BCB Medical. Here you can see this picture from Gartner consulting firm, where they predict that most of the data that will be used for artificial intelligence uses in 2030 will be synthetic. The reasons for this is that it's often difficult to get this real world data, this real data. For example, it's you can't get that much of it, and you need more, or there can be some regulatory issues, which is often the case in this medical field. So we will see whether this prediction will be true in 2030. The healthcare sector is pretty conservative, but if there are some successful applications of this, then I'm sure it will kind of explode. In the healthcare sector, there are many actors and many viewpoints. In this image, you can see that there are the patients who unfortunately they have some illnesses. They see a doctor, they see a nurse, and each time in Finland we have quite advanced electronic health records, and when every time that they see somebody and an operation is done on them, or some lab tests are done, there's always a new line in the database, and so there's quite a lot of data. In Finland, there's only 5.5 million people, but still that's enough to investigate many diseases. Maybe not some rare diseases, but still it's a big population if you have good quality data. On the top, there's this ethics principles, regulations. That's probably something that doesn't exist in every sector. There's a lot of ethical principles. The patients have their rights, and the hospitals, they own their data, and there is this data security. So a person's personal details must not be leaked out from the system. And then there's a lot of these technical issues, like storage of the data and accessing it, ensuring that it's safe, and somebody always controls which data goes where. And also in research, the quality of the data is essential. If you have some kind of non-uniform doctor's notes, it's not so easy to make interpretations from those or build AI on those. But if you have good quality structured data, then it's much easier. So this slide shows why this synthetic data in healthcare is on the rise. As you can see, there have been in 2021, there was within a year, there was 40 million healthcare records that were exposed. That doesn't necessarily mean that it was 40 million people, but still that's a lot of records, and they can be very, very intimate details. In Finland, we had this big case when this psychological company that does psychotherapy, their entire database was stolen, and it was a very big scandal because very intimate details about people were leaked out. Now, when you do science in this health data, you have to share data. If you look at just one hospital, then you don't have to share data, but often it's so that the population differs from place to place. And if you try to develop some AI based on just one hospital, it may not work as well elsewhere. Even inside Finland, if you look at the northernmost hospitals, their population is different from the southernmost hospitals. So if you build an AI model in the north, it may not work in the south. And also the differences are even greater when you go to other countries. So here are some ways of how you can share data. First of all, you must have this universal data format so that you know exactly what the lab values from one system, what they mean in the other system. You must harmonize the data so that you can make some general conclusions on that. And for sharing the data nowadays, it is not so popular, and there's a lot of regulation in just sending real patient data abroad. It's forbidden in many places, and there's a lot of data security issues, and it's slow and bureaucratic. But synthetic data, it kind of it can be used in place of that direct patient data transfer. You create these synthetic patients. They very much resemble the original patients, but they are not real persons, so there are no privacy issues because the synthetic patients don't have any such rights as the real patients. Another way is doing this federated learning. You have an AI model and you learn it with local data in several places. The data doesn't move anywhere, but you learn your model in each of those places, and then you have this global model where you combine all of that. So this is a more technical issue. It's difficult to synthesize properly this healthcare data. Here you see this table with there are patients, they have different ages. Some of them have diabetes, and then they have this blood glucose values. In diabetes, the blood glucose values become abnormal because the pancreas doesn't control the blood glucose as it normally does. So if you look at this simply, you see that there are 3 columns. If you create synthetic data, you just create new columns, and you look at the distribution of the ages. You fill the new age column with a synthetic age column with a similar distribution of ages, and so on separately for this diabetes, yes and no, and for those blood glucose values. But that's not that doesn't work with health data, because there are these hidden dependencies. For example, if a person has diabetes, then the blood glucose values can be different. And when you do research in the medical field, then those hidden dependencies are just the ones that you are interested in. So you must preserve them, otherwise the data is useless. This may be a bit different in some other fields like physics or finance, or in the finance world. If you create synthetic data, there's not always this hidden dependencies, but in health data there is. So you must model the things behind these separate columns and create new columns based on those models, and those models are machine learning models. So here's this one method that has been pretty popular, this generative adversarial network. In this, you create 2 neural networks. One of them creates these synthetic samples, and the other one tries to classify. It is given real samples and these generated fake samples, and it tries to classify which one is fake and which is real. And the neural networks, they are all the time they are trained to do their work better. So all the time this synthetic data generator learns to create samples that are more difficult to classify as false, and the discriminator network, which classifies the samples, gets better in classifying which samples are real and which are fake. So these both learn at the same time, and finally the generator is so good that it can create very good quality fake samples. This this GAN architecture has been used in many fields. For example, images that have been created. You have also images that look very real, but they are not real. Many of them are created with this GAN architecture, and it can be also used for structured data. It's a pretty efficient way of doing that. Yeah, so that's all from us. We are looking into we have this technology for creating synthetic data, and we are hoping that the market will pick up as expected. Then we are already capable of creating this synthetic data. We can look at this one earlier slide. Yeah, you can see on the right hand side there is the hospitals and their local environments, and then there's the researcher pharma company is on the left side on the upper right hand image. So the idea is that the hospitals, they create data, the data stays inside the hospital's firewalls. There is this algorithm in the local environment which creates synthetic data, and that can be shared quite freely. That's the idea, and below we have that our Finnish FinData system, where there is this FinData authority. You can ask FinData, give us this and this data, they will get the real patient data. It will be pseudonymized, and then the researcher and pharma companies, they can access it in the FinData secure computing environment. They don't get it to their own environment. It stays there on the FinData environment. Okay, but thank you.
Thanks for that. I have to say that's fascinating, because I think for a lot of people who are new to this area and don't understand, I think you demonstrate here the need for this and also the opportunity. So that's helpful. And I think that's, for me, lots of questions, and certainly the one about transporting data from country to country. Everybody wants to invent their own rules and regulations. So and we've seen that during the COVID crisis as well. So I think there's an ample opportunity there. So thank you for that, both of you. Very interesting. We're going to move on to our next speaker now from the University of Turku, Antti, who is going to talk about privacy preserving synthetic health data. And then following that, we're going to jump on a plane and go to Greece and hear what Greece are doing in this area. And then we're going to go to Portugal. So Antti, the floor is yours.
Thank you. I will actually pretty much continue from where Jussi and Liselotte left off, though we didn't coordinate our presentations, but I think previous presentation gave pretty nice background about this idea of synthetic health data. So next I'm going to talk about this challenge related to that. How can we say about the privacy? What can we say about the privacy aspects about this synthetic health data? How can we guarantee it? And I am representing here University of Turku, where I'm an assistant professor in health data analytics. And this is related to this large Business Finland project we have been doing for a couple of years together with leading companies like BCB Medical and a group of this kind of cross-disciplinary group of researchers having computer scientists but also people who know more about this ethical and legal issues related to synthetic data. So there are many use cases for synthetic data, like data augmentation and so on, but I'm now focusing on how do you use it for replacing sensitive data like healthcare data for the purpose of sharing. So this is valuable for scientific research, innovation, development, and teaching, and also pretty much all the important AI systems these days are based on machine learning. They are taught using real world data. They are tested, fine-tuned using real data. So if you don't have this kind of data, you can't really do AI. But as we all know, this is extremely sensitive data, not just leaking the fine details of this data, but sometimes just the fact that some person's data was in some given data set might already be a violation of privacy. For example, if that data set is about some rare illnesses, then maybe that person, no, you know already that this person then has that illness. So, okay, to process this data to share it, we would need to anonymize it. But anonymization is in some ways almost impossible problem. So there are many of these real world cases where you have people have shared some data which they were convinced is completely anonymized, and then somebody comes in a couple of days or weeks and so that look, I just found your own medical records here. This has actually happened. Just to give a simple, well, not a simple, but well-known example is that a quite big thing in machine learning in developing these recommender systems maybe 15 years ago was this Netflix $1 million prize. So back then Netflix was still using this system where the users were rating movies from 1 to 5, and they were releasing this large data set of movie ratings from their customers, which was supposed to be anonymized in a way that it should be impossible to tell who is who. The only information they released were, you know, some kind of a made-up ID number, the review scores, and then you have some kind of, with some additional statistical noise, you know roughly when or in which order these ratings were given to these movies, but nothing else about these people. So how do you hack this? Well, soon some researchers were able to find out the identities of many people in this data set just through linkage attack, finding some additional data from IMDb where people were using sometimes their real names. And surprise, surprise, if you have even just 5 or 10 movies, you know the ratings given roughly the order they have been watched. Suddenly these rows of data start to become unique, and you can link people that use person's identity, and then you can maybe find out something about this person, political affiliation, or some other things, just that they watch some embarrassing movies which they maybe don't want everybody to know. So it's a very difficult problem just by doing some kind of ad hoc rules or thinking that, you know, if I just remove this and scramble that a bit, that will be enough, because it depends really on what kind of methods the attacker has, what additional information they have available. So synthetic data has been proposed as a solution to private data sharing, that it's not anybody's real data, but you replace the data with synthesized records. So could we make synthetic data that would give roughly the same results as the original when you are doing your analysis on modeling or software testing or whatever your use case is, but where individuals can't be identified anymore, that it's not real people anymore. So as Jussi already discussed, so here we assume that you have some real data you start with, and you are fitting some kind of a statistical model or machine learning model to this data, a generative model, and then you start sampling from this generative model a new data set of imaginary persons, such as the generative adversarial neural network we just saw in the previous presentation. So we are not happy with getting just some random numbers, but you would want it to be anonymous, that it's just not copies of your original data set. I mean, of course, by random chance, maybe some of the new data you generate could look pretty similar to something you had, but it should not be copying what you had in the real sensitive data. It should look like real data. Well, everybody's now has been maybe many of you have been playing with these generative methods like this DAL-E or this language model based, like you can interact with the ChatGPT. So here is a person who does not exist, but has been generated by a generative adversarial neural network trained on real human faces. And it should be useful. So the usefulness, of course, depends on the context of use, whether you are doing basic software testing, clinical decision making. Do you need to model just a simple dependency between two variables? Are you going to do a complex analysis where you would have to combine some imaging data and patient demographics and what kind of medicine they are using, where you need to preserve a really complex relationships in the data? So one issue to consider is when you are using these complex machine learning methods to generate your data, that it's just because data is synthetic doesn't necessarily automatically mean that it's private. So here's something, this kind of predictive model from this XKCD comic. You could imagine somebody using this ChatGPT, long live the revolution, our next meeting will be at, and then the system predicts where the meeting will happen. Or you could imagine using from a hospital text from real people's medical records to train this kind of a method, and then you start asking that actually what disease does such and such person have, or just generating new records, and you start to notice that actually I'm seeing some PCs, some information leaking from real person's data. So there's a solution. I don't have in this presentation time to go into the specifics, but I will give some practical examples how this mechanism works in action. So one go-to standard for actually proving that your synthetic data does preserve privacy is a mathematical guarantee of privacy called differential privacy, which was originally proposed in research in databases, but has since then been extended to generative models and to machine learning in general. So you have this kind of a guarantee that just based on some algorithms output, you can't really tell if some individual's data was in the original data used to train this model or used for doing this analysis or not. So you are supposed to sort of preserve the main trends in the data, but not leak individual details from it. And it's not an on or off guarantee, but the degree of privacy, which can be then controlled using a certain privacy budget parameter, often called epsilon in the literature. So the first methods for which this was implemented was just for releasing aggregate information like counts, means, medians, results of statistical tests. Even a mean could leak information if you want to know that I suspect that Bill Gates lives in one of these 10 zip codes. So let's ask for the mean income. One person is enough to shift the income, mean income in this case, enough to leak this information. This can be used for releasing synthetic data or even for proving for some neural network classifier that you can't reverse engineer from studying it individual details about people whose data was used to train it. And this is, I would say, still an experimental technology, but it's gaining ground and it's already been taken into use by some quite high-profile companies and, for example, US Census Bureau in releasing some data. And the challenge here is that it has really what this epsilon parameter controls. So, or if you are using some alternative approaches, there is this kind of privacy and utility trade-off. But if we would want to have the perfect utility, the best possible data, we would just release the original data as it is, or randomly sample from the original data, and that would be our synthetic data. But of course, we are then leaking all the information. If we would want to have perfectly private data, you would just throw the data away and fabricate something or do random noise. But then here, we need to strike this kind of a balance that we preserve the main trends in the data, but not the too fine details. So when we are applying, for example, this differential privacy, let's start with the histogram. Just a simple example, these are people's ages, and we want to privatize it so that you can see that this one person who's 120 years old actually was present in our data set. So adding this private noise would basically mean randomly adding and subtracting people here and there. So when we don't have any privacy, we resample a new data set, but it's not the same, but it still has pretty much the same shape. When we increase more and more privacy, there is this disadvantage that at some point we do lose all the real information we had in the data. Or with the generative adversarial neural network, where this generator and discriminator compete when building this synthesizer, we actually implement this kind of a privacy barrier in the stochastic gradient descent algorithm used to train the generator. And we can see that if the privacy parameter epsilon is not set to too much privacy, we can generate, in this case, cardiac patient data, from which you can train a classifier for cardiac diseases that works pretty much as well as one trained on real data. But as we increase privacy, and in the end, we end up with random level performance. So to conclude, well, we know already that access to real world data is crucial and ad hoc anonymization is not reliable. And synthetic data is a good solution for privacy preserving data sharing, but it's not automatically private. So a good question to ask is that, okay, so how can I guarantee this privacy and what are the trade-offs in enforcing this privacy? And that's the main message of my talk. Thanks.
Thank you for that. I think it's, again, this is for many people a new area, and I think it's a great way to sort of pose some questions. So we've looked at some great examples of work undertaken already within Finland. And you would think with what we've seen now, this is where all the answers lie, but they don't, because we've got some fantastic input now from both our Greek colleagues and colleagues from Portugal, from our ecosystems there. So I'm really pleased to welcome Dimitros. Dimitros, the floor is yours to tell us about how, from the Greek example, SMEs can start accessing and using synthetic data.
Yes, thank you very much, Andy, for the introduction. Greece, of course, is a different case, and my presentation will drive you through a slightly different perspective on the use of synthetic data for health for SMEs. So I will first start by introducing myself. I'm the director of the Hellenic Digital Health Cluster, which is a newly funded cluster in Greece. It was funded in 2021 and it focuses on the further development of the most important entities active in the field of digital health in the country, and the strengthening of their innovation capabilities. The Hellenic Digital Health Cluster offers targeted services and activities focused on innovation, cooperation, and growth. Members of the cluster come mainly from the private sector, aka SMEs, and its members include the hospitals, IT companies, spin-offs, startups, innovation parks, legal firms, health technology assessment companies, etc. Greece, as a country, ranks 25th among the 27 EU member states in the 2022 edition of the DESI Index. Regarding innovation, Greece belongs to the countries with moderate innovation performance, in contrast to Finland. And Greece is very high in the growth rate of innovation. And in fact, it has twice the percentage of the average growth rate of the European Union. When it comes to SMEs, and particular to SME digital startups per population, the country ranks 26th among the 27 EU countries, but with unexpected growth for 2022 and 2023, which is more than double the average growth of the European Union. Unfortunately, according to the Open Data Institute, Greece ranks amongst the least prepared countries as far as the secondary use of health data is concerned, where the stage of implementation is less advanced. Greece lags in data availability, and a joint ministerial decision is still pending from 2019 on the availability of national health system health data and for commercial R&D purposes. A proper process for accessing data is still not in place. So that's in contrast with Finland. Apart of that, and despite the fact that Greece shows low digital performance, in recent years, important steps have been taken towards the digital transformation of the Greek public health system. There are several sources of digital health data, such as the services of Idika, of EOP, data from hospitals of the country, diagnostic centers, health regions, research programs, etc. In March 2020, the operation of the national portal gov.gr started, and although started offering a centralized point for accessing all these national services. Although significant progress has been made in linking hospitals, regional health systems, and primary care centers, still there is no unified access to electronic health records at a national level. Of course, there are some ongoing actions that have already secured a significant amount of funds for the development of the national EHR the next few years, actions for the improvement of digital maturity of hospitals, the digital cancer management program, and the expansion of the national telemedicine network. All these projects are expected to shape usable data sources in the coming years. Now, regarding the startup ecosystem in the country, according to a recent study, more than 50% of the startups are related to digital health solutions, mainly for disease management, telemedicine, and wellness. More than 65% of companies are in the initial stage of development. 57% look for mentors and advisors, and 40% of companies consider that state intervention is needed for improving access to government funding programs and for the facilitation of clinical trials. It is important to note that health tech startups represents the highest portion of the total number of startups that have been registered in Elevate Greece, which is the national startup registry. It is a fact that there is a huge demand from governments and the public and healthcare providers to quickly introduce new technologies across health services in order to improve patient care and experience, of course, and increase operational efficiencies. Today, half of digital health solution providers claim that their development and life cycles for digital health solutions take less than 18 months, while 29% said the same in 2018. Regardless of the type of solution, today's market shows that medical device manufacturers, for example, need to iterate every 2 to 3 years and not once in a decade, as was the case in the past. Also, digital healthcare solutions, which are in the development phase, remain stable, and almost 30% are currently in the testing and validation phase. So there is a very big need for shrinking the time of the introduction of new services, and also shrinking the test and validation phases. This is where the European Digital Innovation Hubs come in place. And with their support, companies can improve their business and production processes, and SMEs can gain access to technical expertise and can follow, of course, the test before invest model, which is a newly introduced model. Greece has 7 ecch, 2 of which focus on health, Smart Health, which is co-funded by the European Union, and Health Hub, which is expected to be funded by national funds since it has the seal of excellence. Now, edicts are expected to accelerate the digital transformation of the private and public sector across the European Union by transforming 75% of EU companies into cloud, artificial intelligence, and big data. You can see the figures that are quite low at this point at the European level, 34% regarding cloud computing, 14% regarding big data, and 8% regarding artificial intelligence. The target for all of them is 75% by the end of the decade. Of course, the figures for Greece are even lower, so there is a lot of effort needed for raising the digital maturity of SMEs, which is expected to create new European value chains, challenging high service costs, low patient satisfaction, and reputation risks due to security breaches. Trustworthy artificial intelligence, which is one of the aim for the next decade, requires reliable data, and by saying reliable data, I mean data communities, data sources, and data services, and of course it requires significant computing power. Nowadays, data sources are more diverse than ever, involving different types of data, as you can see in the slide, all linked to the health status or healthcare delivery. All these types of data require highly skilled experts in areas similar to the one highlighted in the Smart Health ecch, Greek ecch, offering in order to be properly utilized by SMEs towards digital maturity raising. Now, in the medical and healthcare sector, as has already been presented by the speakers of this panel, synthetic data is used for testing certain conditions and cases for which real data does not exist. The collection of real-world data faces many obstacles at both technical and institutional level. This is something that is not an issue for only for Greece, but it's a global issue. Particularly in Greece, the low digital maturity of the healthcare organizations, the heterogeneity of information systems, the lack of standardization and interoperability, as well as the outdated organizational framework, make up a particularly difficult environment for our country. Those working on doing research and relevant projects on fire in Greece certainly use data from synthetic mass, synthetic CMS, synthetic public use files, and MIMIC. These are some data sets that have been explored in the past. The main reason for someone to use synthetic data is mainly for getting access, easier access to data, and also for amplifying and augmenting already existing data. I will conclude my short presentation by stating that although synthetic data still is not a complete replacement of real-world data, if somebody focuses on twin data sets, data that combines both synthetic and real data, this can be hugely beneficial for researchers, analysts, developers, SMEs, and the entire community. There are many challenges, of course, that are very similar to the ones that are relevant to accessing the real-world data, such as data quality, data readiness, the governance of data. This is related also to health technology assessment, skills development that has to do with skill sets required for the creation and for the use of synthetic data sets. Still, the utility of synthetic data is still not understood by SMEs, at least in my country, and there seems to be an absence of relevant legislation. That's a European issue. Synthetic data poses a lot of advantages, some of which you can see here, and then potential towards accelerating growth is high if they are properly utilized. Thank you for your attention.
Thank you for that, Dimitrios. Fascinating insight into the situation for SMEs within Greece, and different model again from what we've been hearing in Finland. I think there's a lot of connections there between yourselves and colleagues who've spoken before. And certainly I know from the participants we've got in the chat room, in the audience, there's colleagues there from Australia. I can see George Margelis is there, fellow Greek, but also living in Australia with our Australian ecosystem. Will be interested, I'm sure, in connecting up some dots. Great to be able to see that happening, and I think opportunities for collaboration there. Let's flip again and go from Greece, and I'm going to invite now Ricardo from the University of Porto to share a picture from Portugal, because again, we've seen the picture from Finland, we've seen the picture from Greece. Ricardo, tell us what's happening in Portugal.
Oh, well, I'm going to share my screen. I hope you are seeing now my.
Yes, while you're doing that, I'll just let the audience know, if you've got any questions, the chat function's slightly disabled. If you use the Q&A, we can line these up for our speakers afterwards. Ricardo, please, back to you.
Okay, thank you. So I'm going to try to present a little bit of the landscape in Portugal. And actually, for this presentation, we managed to get some data from potential users, and so I think it might also add on top of the rest of the things that we have been hearing, and it's a good thing to be the last one, so I can work on top of what my colleagues have already said. So one thing that I'd like to stress is that the knowledge of most of the health institutions in Portugal about synthetic data is very low. And actually, what we did, we just managed to ask, well, some of the hospital CIOs in Portugal, and I can tell that the guys that we actually asked for are the most dynamic ones. And well, most of them have never heard about synthetic data. So I would say, Andy, we need here also to promote these things near the CIOs of hospitals. And so I would say that there is a need to get the information to the hospitals at least, and maybe even promote this type of events near the CIOs. And all of these CIOs are people that are very sensible to the question of protection. Portugal actually has been one of the countries in Europe that has suffered a lot from, for instance, GDPR fines. And so these people are sensible to this topic, but still don't know enough about the potential of synthetic data. Then what we did also is try to find out, okay, how are the researchers in Portugal dealing with this? And so we managed to make a search on Medline and to see papers that were referring to synthetic data and had some Portuguese authors. And so it's interesting to see that, well, there are some areas. The first one, medical informatics statistics, well, these are researchers that are actually working on methods. So not on any particular medical area, so just on methods. But then you see, for instance, for neurology, there are a few people working on this, cardiology, geriatrics, biomedical engineering, and then many others. And I would say that here we can, at least in Portugal, if we want to promote synthetic data, we need to get the researchers and try to involve them also in promoting the area and saying how they manage to do it, and then proliferate these experiences throughout the country. Well, we went to look where these guys are, and so it's not just one university. So as you can see here, well, there are some that are on top with more articles, but it's fairly distributed in Portugal. I can tell you, you don't know probably the geography of Portugal, but you have people working on this from north to south, and even on the interior also. So it's fairly distributed. So there is an opportunity here to put these people to work with at least the CIOs from hospitals, and so we have the experience on one side and the need on the other. Then regarding the SMEs, this is some companies in Portugal that are working with synthetic data. Some of them are working, for instance, the first one is using this in projects regarding sensors. So they work with sensors that collect vital signs from patients. Then you have companies that work more on imaging or on orthopedic surgery. And we have even a company that is working in projects in Denmark, and although it's not using synthetic data in Portugal, is generating synthetic data elsewhere. And although they are not specific to healthcare, we have this big company created by Portuguese, this is Wide Data, that it's actually focused on synthetic data. So again, we have some experience in Portugal dealing with synthetic data, although again, the hospitals don't know about it, we need to get this information to them. Then as a final slide, I would like to show a little bit on what's the experience of one particular SME that I'm involved with, because I would also like to tell you some of the difficulties we deal with in every day. So we have been working with synthetic data mainly internally for our development and testing. And we also do as a service pseudonymization, so this sometimes is useful. but it's very intriguing because typically when we talk with clients in the first meetings, everybody says that they have data will not be a problem. It's easy to get it and to generate, for instance, models on which we can then create synthetic data. But after this kickoff meeting, when it gets to the technical meeting, well, the message somehow changes. And so I would say, I don't know, I'm not sure if people are too optimistic or not, but it's a different message from the first to the second meeting. And the thing that I wanted to stress here is that, well, this company works a lot on interoperability, which is something that has already been focused here. And I really think that one opportunity in healthcare is to work with data that has already been standardized to regarding integration between systems. Because if we manage to have access to that data, which is simpler, and then I can, in the Q&A, I can answer questions on it. If you can access the communication between systems, that data is standardized. Typically, we understand the data, and so it would be much easier for us to do to create synthetic data on top of it. So regarding getting to the sources, this is a way to move forward. And one other message that I would like to say to people that well, may not know synthetic data that much is that of course we always want the maximum quality regarding synthetic data, but even low quality synthetic data is useful. And sometimes I think we should think that we have different levels. We might have low quality synthetic data that, for instance, guarantees much more the security part, and it's useful for some tests, for instance, and then we might need very high quality synthetic data that has higher risks regarding security, but is useful for other things, for research, for instance. So I'm not really sure, Andy, that if you are needing some type of to categorize different levels of synthetic data, but I think it's something that people need to be aware. It's not one size fits all. We have different opportunities to take advantage of this. That's it, Andy. Thank you for the opportunity.
Thank you for that. And I think straight away, I'm seeing opportunities for collaboration between colleagues in Greece and Finland there, because you've obviously hit the nail on the head in terms of CIOs have, no clue about this. In a gross sweeping generalization comment I can make, because I can, and I think we've seen opportunities there in Greece as well. I think we've seen some great opportunities also in Finland. We're going to explore some of these a little bit more in the Q&A, hopefully the discussion session later. For now, though, I'm gonna take us back, literally get on a plane, because we can go back to Turkey, and we've got Arhu, who's from Turkey University Hospital. Let's get down to the use case for this, and hear from you in terms of what you've been doing in Southwest Finland, and get practical.
Thank you very much. Hopefully the image is showing and voice is okay, very good. So I tried to continue from the topics of the previous speaker, that there are different categories of data. My intention is not to bore you out, but I take a bit broader perspective first. So because I work in a hospital as a chief analytics officer, there's lots of data and lots of use cases. So I go through a quick overview where the data is used, apart from the obvious patient care, and then the different categories, because it differs. You have lots of different data types in hospitals. Then I dwell into the concept of synthetic data. So what is it and what is it not? And then I discuss a bit about what could be the use cases. And the background for this is that we have a large reform ongoing in Finland, and we have a new legislation called the Law for Secondary Use of Social and Health Data. in connection to that, the Ministry of Social Affairs and Health have established a team or a group of experts. That's actually required by the new law, that there's a team of information security and data experts that give advice to the Ministry of Social Affairs and Health, what kind of measures should be taken and how the data should be handled. And as part of that work, we have tried to categorize the different levels of data, and I will go into that category. But as a reminder, in the beginning we were talking about the confidentiality of the data, but the legal what we should be doing here in the hospital, of course, treat the patients, but also provide teaching as part of the university hospital and do research and support research. And the data is used in addition to the research and innovation work. In the work of a doctor, when the new students are becoming doctors, then they need to do their studies and use the data. And then it's a new thing in Finland that we have data-driven management, and that's also required by the law, that we need to know our data and we should be using it to manage the healthcare system. And Varha, which is a new entity, it's quite large. We have 23,000 people working, and it's really a huge entity, ranging from primary care to the specialized healthcare in Turku University. And what data is there? Of course, the categorical data is something you are familiar with, the core data, the master data, the patients, but also the visits, treatments, drugs given, all the categorical and numeric data. It's not that much, but it's anyhow a couple of terabytes. And then we have signal data from remote sensing. For example, this signal is from CPAP device. If you are a snorer, you get the device that makes you easier to breathe with a little bit of pressure. And then the pressure curves are recorded, and then they are sent back to the hospital, and it even computes the events of apnea. So those events you couldn't breathe. So this is part of the treatment. And then, of course, the imaging data, also 2 and 3D. So these are the data categories roughly. And we have been working in the support of the secondary use. And starting from 2014, we have been delivering more than, or roughly 2,000 data sets to the researchers and for other purposes. And typically the researchers want to know the diagnosis, demographics, procedures, lab values, all kinds of visits, but also the texts that are written in Finnish about the patients. And then there are imaging, that's a large category of data, but these data types differ. Generating synthetic images is a different story than generating synthetic patient text. But as a background, I won't go into that, but I will share my presentation that our clients are both the medical doctors, university researchers, but also all the largest medical companies, because they need to assess the real life effectivity of their drugs and the safety. And because they can come to us, to Finland, and ask services from us, we actually do the analysis for them also. So it's secure that they are not getting the data, but we also do the statistical analysis for them. But now to the interesting slide. And this has been changing during the last years when we were discussing in the high-level group under the Ministry of Social Affairs and Health. And I started with 4 different categories, but through iteration, we finally got into this sort of consensus view in Finland, and it comes from GDPR regulation. And it's split into whether it is personal information or not personal information. which is not covered by GDPR, nor it's covered by our own laws. But if we start from the easy ones, the original data, it's the individual up-to-date personal information, and that's heavily needed in the hospital. Technically, you could have the blood samples just labeled with numbers in the laboratory, but for security, there's always the social security number put into the blood sample, not just the sample number, just to make sure that the samples are not getting mixed. So there's lots of redundant personal information in the data because of the patient security, that we do not mix the samples. That's one thing. For research, it's easy to identify the data. We do not reduce the accuracy of the data or do any categorization, because if it's for scientific research, GDPR allows, and our also national laws allow that we can give full resolution data for research, but the data needs to be given into a secure audited environment. And we have one such Linux environment in our hospital, but there are several of them in Finland, but it's heavily regulated. You cannot freely install stuff there, and it's a two-phase process, first to install the stuff, and then only after that you get the data and so forth. But anyway, this is also high quality data, like the original one. And when we are talking about synthetic data, actually intentional bootstrap resampling and all the methods that you reuse the old data, they actually are sort of synthetic data when we go to the definition of synthetic data, what we usually use. And let's stop here. Go to the other extreme, the fabricated data that's typically used in software testing. You just make up some names and some addresses and put up mock-up data with no statistical content, but anyway, it's usable for software testing. And then we also like to distinguish simulated data, like the pandemic forecasts that we saw during the COVID-19 pandemic, and other forecasts that are generated from a mathematical model. And there's no actual background data, just a mathematical model. They are not personal information, and there's absolutely no residual risk because there's no data set behind. It's only a model. Okay, going towards anonymous data. And this was something that caused confusion in Finland, and I was part of the confusion. But then somebody noted that according to GDPR, the European regulation, anonymous data is irrevocably de-identified data, and it's impossible to determine from whom the data point was, practically. And if somebody saves the code key, so you have coded data, and you have disposed the key, then it's anonymous. But if the key is stored somewhere, and sometimes it needs to be, like in biobanking research, if you find by coincidence something, you need to call to the actual patient that we were doing just research, but we found something, could you come to the hospital for checkup? Then you need to go to the code table. But in GDPR sense, if the data is anonymous to the person who gets it, but there's code somewhere, it's pseudonymous, otherwise it's anonymous. And then we finally get into the synthetic data, and it's convenient to define that it's derived from real data, to distinguish it from simulations. It's anonymous, in contrast to ordinary bootstrap. That's an old technique in statistics, and it has similar statistical properties with the original data, like the previous talkers explained. So this is the definition we at the moment use, because this proves to be useful, and I would say that it would be highly valuable, but it's quite complicated to prove that it's really anonymous the synthetic data you're generating. In contrast, it's quite easy to just resample the data or make a poor GAN model that repeats the original data or is otherwise non-anonymous. Okay, these were the definitions, and then some tests within our hospital. So the red one is original data cloud with quite a large N, and because it's a big data set, it was easy to apply kernel methods to generate similar looking synthetic data set. But of course, this method fails when you increase the dimension of the data. And K-anonymity is the old rule that has been used for decades in hospitals, but the differential privacy is something we should definitely have a better understanding and look forward, because it's really rigorous framework, perhaps even too rigorous when it comes to the initial assumptions behind of that theory. Okay, right. We had these different categories, but how we use the data for ordinary reporting, it suffices that we use the original data and, for example, draw steam graphs. This is not from our hospital. This is our state's budget from Helsinki newspaper from year 2020, and it's immediately easy to see without any statistics that the green big flow here is the Ministry of Social Affairs and Health. So because we are a welfare country, we are using quite a lot of money for the health and welfare. Next, for the
that's the biggest slide I've ever seen. I think I give you the congratulations. That's the best slide I've seen all day.
Okay, but anyway, notice that you can produce these sort of presentations without any p-values or statistical confidence intervals. It's easy to interpret these images without any knowledge of statistics, and it's visual analytics. Okay, but when you go to the statistical analysis, let's say that, okay, when you get one treatment, then your probability to survive is much better, the red one here, the cumulative incidence of relapse, so getting relapse with given disease. So it's quite easy to see that the new treatment is better than the old one. I don't know actually where this comes from, but I got these slides by going around in my team and asking my analysts that you have nice looking stuff on your screen. Could you take a screenshot and send to me? I'm going to have a presentation shortly. Okay, the statistical working and then physiological modeling, just for completeness, where you actually make lots of assumptions how the blood flows in the veins, and then you model. But this is more like academic medical research than data driven, because you only need little amounts of data and lots of physiological assumptions, and then you simulate, like in the pandemics. You get the model and then you run simulation. And then what could the synthetic data be suitable for? This is one characterization. Katarina Perkonoja is one of my students in University Hospital, and we can say that they identified data. It has the original quality and it's very good, but its utility is restricted because it's highly identifiable. And when you anonymize, the identifiability is low, but it ruins more or less the signal and the correlation structure in the data. And synthetic data, in that we could potentially have high predictive value, high accuracy in the same time when we have low identifiability. And this is why we are enthusiastic about synthetic data. Otherwise, we just would go for anonymized data and anonymize the data completely. But with synthetic data, we could get higher utility. like what the previous talkers were anticipating or discussing, what could synthetic data be suitable for study material, for software testing, first stage implementations of statistical models, exploratory research, model testing, and even pre-tuning models. Like when you do transfer learning, you train the model with something that's sort of the data you expect. And with the pre-trained model, you go to the actual data. And if you have a high quality synthetic data with that similar structure than what you are actually going to study, then it might be helpful. Performance boost, similar to Bootstrap, test material for commercial innovation activities, hackathon materials. Then about the challenges, but perhaps it's more interesting to go into the examples and then I go back to the challenges. Yesterday, I had a student from elementary school by coincidence, and I had a task to show her our unit, and I had 2 hours, and I decided to show that, okay, this is our database. This is what we do in the hospital. She was interested in mathematics, but she was in the elementary school, and I guess that her age was 16. I showed her that, okay, we have got lots of source systems here. As you see, our data is scattered. And then I went to show the data, and here we have the master data table speaking about the patient. And of course, if I do this with the original data, then it's an obvious hazard, because it's a very bad idea to show the master data from university hospital. Perhaps she would have noticed her relative's name or uncle's name or whatever. But with synthetic data, I was completely safe in showing that this is what the data looks like, and it has lots of different categories and properties, and the tables are wide, and hands-on feeling what it looks like. So for the introductory presentation of what real-life hospital data lake looks like. And then this is not my slide, but I borrowed this from fellow researcher in Turku, and PET Center is located in our hospital, and here we see that if you use data replication techniques, more modern than Bootstrap, then you could, with the assumption that, okay, with low dose you get an image, and then you assume that the image would strengthen if you add up more radioactive substance. You can extrapolate the actual image from the original image. Of course, this works only in those cases where you can safely make the assumptions that the image will get stronger if you continue giving the exposure. Of course, for time-separated mass spectrometry, this wouldn't work by definition, but in those cases where it works, you can use it to lower the amount of radiation. And then I had access to Antti Airola's slides, and I wanted to play out with this person does not exist pages, and I got more faces that looked real. And you saw this already, but for people who haven't been visiting that page, it's quite an eye-opener. But back to the challenges is that picking the method, it's not straightforward. Similarly to the fact that there's no single algorithm that would anonymize any given data. That would be brilliant, but unfortunately we do not have any such algorithm. And if we had, I bet that would be part of the Finnish law and part of the coming European law, that you need to apply that anonymization algorithm. But there's not such thing, no such thing. And for generating synthetic data, it's a similar thing. The methods work differently, and then how to assess the quality of the data. And as the previous speakers noted, that sometimes it suffices that the data looks the same as the original, as you saw in the slide what I showed to the elementary school student. So it suffices that it looks correct. It's already high quality enough for software testing. And then if your distributions of variables are similar to the real ones, then you could use it for pre-training statistical models or practicing in the secure data environment when there's no real data yet, and you can install your own software and machinery before the step that you get the actual data and you lose the internet connections. You can only take remote desktop and use the data processing environment as an isolated sandbox. And then we have also noted that the definition of synthetic data varies. And when discussing with people, some use it synonym for simulated data, and it's not very helpful. And because of that, we just decided to define synthetic data as generated from real data. It's similar to the real data, and it's anonymous. Then it makes sense, but the definition varies. I'll stop my presentation to this slide, because this is something that if you can give or provide me criticism that I have missed something, I'm more than happy to correct or add to this categorization.
Well, thank you for that. You've certainly been focused on an enormous amount of information there. And I think thank you very much for that. I've got a question before you go. I've got a question in the Q&A. Okay, from Kari Heinonen, who says, let's assume that you have a synthetic data set and the real base data changes over time. Can you somehow determine how often the synthetic data can be regenerated? So basically saying, I assume that synthetic data cannot actually be updated in the normal sense of the word. Is it updatable?
It is updatable, and I would say that when you generate the synthetic data through a mathematical model, then you can update the underlying model by training it with the new real data. And then when the data shifts or changes over time, if it does that, then your model can they take that into account. And with that mechanism, you can also update the synthetic data.
Okay, that's helpful. Hopefully that's answered the question from the floor. There was another question we've got as well. This is thank you for that. We've now got a whole 30 minutes to get busy, okay? Because we've had presentations, we've got some questions we've had lined up from people who participated. I'm going to use my ability to be able to pick on people. So firstly, I'm going to go to BCB Medical. Okay, I want to ask, given what we've heard from Greece, from Portugal, and from Finland, where's the business in this? Because there's a sort of big so what with this, which is it could be nice, okay, but where's the business case for this? Where's the economic value for you? Can you see for BCB?
Well, yeah, well, from BCB Medical, it's obvious that we want to be international and we want to sell stuff abroad. And in medical research, it's well known that you have to validate your systems elsewhere. If you just build one model and try it in a hospital in Finland or in several hospitals in Finland, there is no guarantee that it will work elsewhere, because if it relies on some measuring devices. They may be different in different countries. They may be run with different chemicals or different protocols and so on. So it's vital that you test your stuff elsewhere to be able to sell it. And besides, the European Union is quite active. We have taken part in some projects and are currently applying for money from the EU in a big project on a system that kind of builds European-wide for these AI solutions. So there is a strong will in the European Union to kind of make this happen in all over Europe. And it's also so that the treatments in some diseases are better in one place. Perhaps there is in some place there is a lot of experience. Some research has been done in some disease. And when you build an AI model there and you sell it elsewhere, then you kind of, at the same time, you distribute that knowledge that exists in that one place. So it's a way of kind of also educating people elsewhere, and it's not just a tool. It kind of also can change the way that things are done in different countries.
Okay.
I can just give another perspective with a pharma background that, like I mentioned, that doing randomized clinical trials, they cost hundreds of millions of euros, and really accelerating the process of that clinical trial using a real world data set that is synthesized is a remarkable way of saving time and resources. And in some cases, it's the only way to do it, because you would never be able to do that patient recruitment so quickly. And also having synthetic data for companies who are doing research for hypothesis testing it's really remarkable. It's something that I think there's a value and a monetary value that really, when the belief, when everybody understands how good the synthetic data is, I think we will have a huge amount of possibilities to show a monetary value of using it. But it comes to, I love the slide about Portugal, where it said, we have data. And then you go into the technical discussion and it's like, oh, well, maybe not available. So that's why I started with saying, if you have the data, everything else falls quite nicely.
Okay. I'm going to come on to, there's a question from Yannick. Just for the pair of you, whilst we got you both on, who else? Because obviously in Europe, everyone says, oh, the Finns get this. We don't understand how to get the business model. The Finns will understand. Outside of Europe, who's doing this right? People from Singapore? Who have you seen that you think, okay, I wish we could do what they do in terms of monetizing this? Or is it just us? And in Europe that there's because I can't imagine that.
Well, on the graph, UK is coming very high. You've been very good in UK, really sharing the data sets and using it in an early stage. The primary care data sets are remarkable. Doing a lot of collaboration, having NICE also very active in the HTA arena is really good. I myself sit in Switzerland, actually, so I can tell everything that's done wrong. And it all comes to the fact that you don't have trust. If in Finland we can do this because we have patients who trust the government and that it's the countries who have built this trust, they have done a good job, and others will be coming behind.
Okay, lovely. Okay, Jana, you had a question, I think, particularly for Arhu.
Yeah, actually I have one question that resonates pretty well with what Liisa-Lotta just said. And the question is that, Arho, in your experience, what kind of original data is needed for building a really good quality synthetic healthcare data? I mean, in terms of coding, data harmonization, and of course, in terms of coverage. there are probably some basic aspects that are put into mix and they make a good synthetic healthcare data.
Well, it's not. It might have been easy to ask, but not easy to answer. But according to the current knowledge, intersectional data, where you have lots of data points, it's much easier than for time series data when the time series are sparse, and then there are different kinds of exceptional paths and only singular. So that only 1 or 2 or 3 persons have gone one treatment path, and then if the data is sparse, then it's hard to get an overview of the phenomenon, even using the original data with all the tools what we have, and then generating synthetic data out of it. Then it requires lots of assumptions, and if you make lots of assumptions, then it's dangerous to use that as a hypothesis generator, because you actually reinvent the hypothesis you have built in the first place. So when you've got lots of data, then it's easier to produce high dimensional synthetic data, and the high dimensionality is the problem when you have only marginal distribution. So it's easy to draw the age distribution or the distribution of all laboratory values across the whole population, but to get into the more complicated statistical structure, that's the problematic.
Thanks. And I also have another question, and this one goes to Ricardo and Dimitrios. So now you know where we are in Turku region, and you could say that where we are in Finland as well, as Turku is the leading region in terms of synthetic healthcare data. In your opinion, what kinds of opportunities there are for collaboration between our regions?
Dimitris, do you want to go first?
Yes, I can go first. Thank you. Yes, that's a very good question, because one thing that it is very important for an ecosystem such as the Greek one is to be in a position to increase its level of maturity in a situation where data do not exist. They exist, but they are not accessible, and they are not accessible in a format that can facilitate rapid testing of hypotheses before moving into the development process. Therefore, I can see a lot of opportunities, because, as I mentioned into my presentation earlier, the utility of synthetic data is not understood, not well. It's not understood almost at all in the Greek ecosystem, and this is also a reason that synthetic data has not been included in any text that is relevant to national strategy or this kind of stuff. So I believe that this gives us the opportunity, first of all, to try to, get in touch and know each other, and also possibly through the ecch can find a way of a more formal collaboration in the near future, which is something that is already here. You know, ecch has started operating only a few months ago, and there is a huge opportunity for the entire European ecosystem to benefit by tailored expertise that is not easily accessible at a regional level. I'm sure that you are aware of the ecch network and ways of collaboration through that channel. So that's a first idea that comes to to my mind, and I think it will probably be the most easy to start with.
Well, I can also add a little bit on what Dimitris said. I would say that one of the problems that I imagine that we are going to have here in Portugal has to do with the trust on the process of creating synthetic data. So I would say that it would be interesting if you could collaborate, for instance, in testing some of the techniques here in Portugal, and have some of the experts that work on security see for themselves how secure those methods are. That would be really, really important for the people, for instance, on the hospitals, then to see, okay, this really works and this is appropriate. Then another thing, I'm not really sure on how this is being tackled in other countries, but there is a discussion now here in Portugal regarding the European health data space. So the proposal that is being put forward regarding the EHDS, we know that's going to take some years for the regulation to come out. But the discussion is that we are trying to put it, some of the things that in Portugal we think are more useful, we are trying to put it in to practice before the regulation comes out. And so I think that maybe if we can have some proof of concepts on some of these techniques, it also can be helpful for us to use this in the roadmap on Portugal regarding the HDS. And the last thing that well, this is like more of an invitation to you all. I really think that some of these techniques go very well with the interoperability area, because I don't know if you have the same setting, but for instance, in Portugal, hospitals have in average 60, so 60 different databases with patient data. So you might think, well, I want the data from one particular hospital, but that means that you have to look for it in 60 different databases and then understand the variables, the database model. Hopefully you'll find some documentation, but it's a hard thing. Again, you have the data, it does not mean that you can actually understand it. Once you go to the deal with data that's being exchanged between systems, then you have standards, and it's a fast way for you to access some of the data. You don't have all the data, but at least the data that you have, you more easily understand it. So I would say that this is an opportunity to make some of these techniques available in a transversal way. If you are using HL7 or FHIR or DICOM, well, then it should be able to use some of these techniques on top of those standards. And we are open to try to make some of these proof of concepts here, if you are willing to.
Okay. That kind of leads us on to, I mean, there's been a couple of points made again from Carrie back in the chat function, was about one problem around the international market for ready-made synthetic data sets might be the lack of truly semantic interoperable codings, terminologies, medication IDs, etc. That's given. I mean, we've looked about that one. Obviously, that might be changed with a European approach. They've also mentioned there's standards. There's usually lots of them, but the adoption level and various use cases varies from country to country. So my question is, from what you've just said, Ricardo and Dimitrios and Jan and colleagues, Jussi and Lizzie, I always when I come to these thematic ecosystems are fantastic in terms of data. Okay, and we've seen lots of data about data, and I see opportunities. Okay, and I ask myself the very complex question. Okay, which is so what? Okay, what can we actually do collectively between Turku region with BCB's involvement with Portugal, with Greece? Where can we connect those dots within the network that doesn't need to wait until the development of these European digital innovation hubs, but can happen now? What can we do now? And then secondly, what do you need? What do you need? So first questions first, where can that collaboration happen easiest, do you think? I don't know if it's worth coming to you, Dimitrios, or Janne, or Arhu, or Ignanti, or other colleagues. I don't know if Ricardo or Lissy, where can that collaboration happen now, given the conversations we've had today?
I think that the most annoying and boring answer would be that if we could identify sources for funding.
Well, that was my second question, so wait your turn.
Yes, Andy, it is indeed a fact that funding is something that is very important, and is something that you cannot do without.
No.
That is actually that's actually why I mentioned the edX, because some of them have already acquired some European funding, and they are already running. So this is the easiest way to start our collaboration, by starting exposing opportunities that are available to SMEs and to the wider ecosystem. Apart from that, there are many other ways of collaboration, as Ricardo mentioned earlier, datathons, hackathons, and this kind of stuff. We have been through this process in the past here in Greece. We know how this works, but in practice, these events are mainly technology focused, meaning that they focus rather on using technologies such as FHIR, CDA, or this kind of stuff, rather than the actual generation and use of synthetic data. Apart from that, there are some opportunities that may need be explored through the Horizon program that can possibly lead us to building a network of excellence, for example, or a network of interested parties that focus on the development of a particular project that we hope to be and to provide important outcomes that will be useful to the society and, of course, to the health systems. So there are many opportunities, and still the most important thing that we need to do is to be in touch, and having us here today was a great opportunity for all of us to get to know each other and try to work further options and paths for either immediate or future collaboration.
Andy, let me just add something on this. Probably you also know, but there are some European projects. One of it that I'm following is Eden, that is promoting a standard. It's OMOP, and so I would say that if we are able to produce some synthetic data on OMOP format, it can be interesting, as people are now testing somehow that format. And I can add that in Portugal, again, we are discussing on the importance of creating data lakes and how difficult it is, how important it is. If you manage to create, for instance, a data lake just for testing with synthetic data using a standardized format like this, maybe it's easier to convince others that the data lake is useful. And so you can pass some of the security issues and then create actually living examples with not real data, synthetic data, but can be you can test on it.
Okay, it's helpful. We've got 2 questions. Let's say I can see it. I'm in no order. I'm just seeing from my screen here. Let's say, and then Arthur.
Yeah, just a quick. Ricardo, great minds think alike. The second before you said anything about Eden, I put it in the chat. I hope it came. It maybe, I don't know if it came for everybody, but there's the website. We're part as a data partner, and I really can recommend it, both for harmonization and funding. Very, very good global portal and good experience from it.
I know we've had some problems with the chat, so what I'll do is my colleagues will grab anything that's been dumped in the chat function, and people can send through links, etc. As part of the follow-up from this, we'll send out resources, the presentations, and links. Links I think are helpful because this is a knowledge sharing exercise. So we'll do that as a follow-up for people who've taken part today and presented in the attendees too. Yeah, there's a link coming in there. And then over to you.
Yes, the OMOP common data model was mentioned, that's something that's needed. And unfortunately, I see it that way, that first you need to convince the policymakers that you need the data lake or data reservoir or raw data. Anyhow, you need to commensurate the data, and the rough estimate of 60 source systems is quite close. I think that we've got more at the moment, but anyway, it's really hard work to put the data together, but it's needed in so many different uses, like quality work to improve the healthcare systems efficacy for scientific research. There are lots of different justifications, and then you need also projects and workers and people to commensurate the model into the OMOP common data model. We have been doing that for 2 years and spending quite a lot of person years and hundreds of thousands of euros, and now it works sort of. And once we got the data in the OMOP model, then what I would like to see is that could we produce algorithms that would work on top of OMOP model, so that if anyone has OMOP formatted data, then there would be a proven way of generating synthetic data that's proven through differential privacy or something like that, that you can really trust that that data can be used for innovation work. That would be valuable. But the first things need to be done first, and to put the data together, that's quite an exercise.
Okay. So we've looked at some areas where we can maybe collaborate. We've looked at maybe questions about where the cache is. Okay, where's the cache is always a good question. The other thing is I always think with we've had an incredible data set today of information around synthetic data, but what are we missing? Are we missing inputs from for instance, CIOs? Where can we bring that in? Because I'm conscious with this, until we've brought all those key players in, we're talking to the converted, as we say in English. We're preaching to the people who understand the use case for this. So how, who are we missing, and what other information do we need? Just a quick question. So who are we missing, and what other information? Listen, what do you think?
I would start with the data, and we see quite easily that the healthcare providers are really pressed with time and energy and resources, and if they can't collect the primary data collection isn't there, the integrations, as was mentioned, you have 60 different data sources and they're not integrated properly, then you're just losing time, and you don't have the people to collect the data for good quality. Especially there's a very clear, I was looking at one of our publications, and those who have initiative to collect the data and they understand why the data is collected, a nurse or a physician, then the response rate is like 100%. But if we can't motivate people to collect data in healthcare, then we won't have good healthcare data.
Okay. Okay. Any other input from that? Ahu.
And the way to motivate would be data-driven management, so that when you input proper data, then you get immediate feedback that how you are performing, what you could do better. And that's something that we are trying to solve at the moment, and it's really problematic and a huge amount of work to do. But we see that also, that if we could offer something back, that okay, want to learn the way you are treating the patients, have a look at these stats, and then the actual healthcare professionals could use the data for their work. That would be the most valuable thing. And then when we have a good data for the primary use, then it could be good quality also for all the secondary uses.
Okay. Okay. Conscious of time, Ricardo, I see your hands up. Yes,
I cannot resist to share with you a small trick that I've learned here in Portugal regarding how to improve quality of data. I'm also involved in creating patient records, and one thing that it really works very well is that if these systems have a curricula vitae option where each health professional can get its own curricula vitae based on the information that he has inserted. For instance, how many surgeries did he did, how many types of patients, then, and this is a way of giving feedback to a person with something that is interesting for him personally, then it works really, really well. And it's an easy option, it's an easy function to create. Okay, so just a small.
I think that's speaking to the converted. That sounds like we need to caress some egos, and putting the egos back into ecosystems, which is always a thing I always try and avoid. But yeah, I understand. Self-interest works great, and I take your point entirely. Okay, conscious with time. Unless anyone else has got any points or hands to raise, I can't see any hands raised. I'm going to thank all our speakers today from both Finland, from Greece, and also from Portugal for taking the time out today. And I think showing such great amounts of research that you've done. I mean, sometimes with these, we can just come up with the blah, blah. And very clearly today, you haven't done. You've educated certainly myself and a whole group of people who have been taking part in today's webinar about the value of synthetic data and where we're at in various countries and the business case proposition. My opportunity now is to offer you a chance to take part in the second one of these thematic innovation ecosystems on health data. And we will be looking, I think, at the value proposition from these European digital innovation hubs. I would like to invite both, again, colleagues from Greece, colleagues from Portugal, and also colleagues from Finland to come and take part in that. We, as part of the ECH Alliance, will extend that net to bring in other digital innovation hubs where we can, because I think these are the ways in which we can actually bake in that collaboration. So personally, I'd like to thank colleagues from the ecch network, well, I always mispronounce. One day I'll probably get it right, but colleagues from Finland for setting this up in the first place. Ricardo, Dimitrios, thank you very much for your taking part. Lissi and Jussi, thank you also for your input, and colleagues from the various universities across Finland and the Finnish network. Thank my colleagues Adriana and Ines and Iman. We will follow up this, share some information, some resources, and with that, we close on time. And thank you very much for your time today. Thank you very much.
Thank you, Andy.
Thank you very much.
Bye-bye.
Thank you.
Bye, everyone.
Bye.
All right.